Okay, so now I am very pleased to invite to the stage PJ Hartnett and Rose Galvin. They're going to be talking about age-friendly memory care. Dr. PJ Hartnett is an experienced healthcare leader with 27 years in clinical, managerial, and educational roles across Ireland and the UK. He is a senior associate at the International Foundation for Integrated Care and adjunct associate professor at the Trinity College of Dublin, as well as being the head of integrated care at Mowlam Healthcare. Rose Galvin is a professor in physiotherapy at the University of Limerick. She's a recipient of the Health Research Board 2020 Research Leader Award, exploring models of integrated care for older adults. She was the vice president of the Irish Gerontological Society from 2019 and 2022, and she's a founding member and the co-director of the Aging Research Center at University of Limerick. So over to you, PJ. Please welcome him to the stage.
Good morning, everybody, and thank you very much, Kim, for inviting me here today. Unfortunately, Rose can't be here. Her mother passed away last week, so she sends her apologies. So I'm going to share work that we're doing in Mowlam in relation to age-friendly healthcare. Age-friendly healthcare is a concept that I came across about 6 years ago. In my view, I think it's the most critical thing that brings together all elements of care of older persons, including those living with dementia. The things I want to cover today really is just to give you an insight into what age-friendly healthcare is, what it's all about, why we chose to invest as heavily as we have in age-friendly healthcare, what we've done, and what we intend to do next. So we're working with the Institute for Healthcare Improvement, and as you may know, Institute for Healthcare Improvement is the biggest, probably the most prominent healthcare improvement agency internationally. And one element of the Institute for Healthcare Improvement work is to build a movement internationally that focuses on improving the care of all older people, irrespective of where older people seek healthcare. So whether that's in primary care, whether that's in an acute hospital, or in any other form of care setting. And age-friendly healthcare is guided by a set of principles, which I'll briefly run through. And those principles are evidence-based set of principles developed by consensus internationally with kind of cascading of evidence down into 4 critical things to be done all the time when you encounter an older person in a healthcare setting. And the major principle behind it is not just evidence-based, but also cause no harm, and make sure fundamentally that it's consistent with what older people want. And that sounds like a very obvious and a very fundamental starting point in relation to age-friendly healthcare. But having worked in healthcare for the last 42 years, one of the things that's very often missing from healthcare is, well, what is it that the person in front of you or that's coming with the issue actually wants? What outcome do they want? What is their will and preference, as we heard earlier, isn't necessarily central to the decision making. So clinicians are typically trained in deficits. We're trained to work out, well, what's wrong, how can we fix it? And that works well if you have an immediate acute need, but it doesn't work well if you have a chronic condition that you have to live with or a disability. The 4 M's essentially consist of medication, mental health, mobility, and what matters to me. And the what matters to me is the most challenging shift that we've experienced in the work that we've been doing. Because what matters to the person is a much more detailed and a much more challenging conversation to have, and it influences all of the other aspects of what it is that we intend to do. And these are not a menu upon which we can select one or other dimension. They all have to be mobilized in unison. So we cannot simply focus on medication or simply focus on mental health or mobility without framing what those things look like for the person in relation to what matters to them and what outcomes they want. So the 4 M's are very elegant and a very sort of simple and easy to remember framework. But beneath them is a body of evidence, but also a lot of technical, technical terms that maybe not necessarily familiar to people when they engage with them, especially when we're looking to engage families and residents in the process of change. So on your right-hand side, you may not be able to see it with the lights. On your right-hand side, you'll see a translation of what matters to me by one of our care facilities who looked at what that might, what does that look like from the perspective of the person who is either a resident or a carer for that individual. And essentially they've translated those sort of principles into into a much more accessible form of understanding what the principles stand for. So, a consensus of international experts essentially got together and looked at the evidence that improves outcomes for older people, and they ended up with over 100 individual pieces of evidence that they felt were contributing to improving outcomes. And they stratified that evidence based on the actual quality of the research. But when they reduced it down to something like 13 elements, it was still too many elements to be able to usefully communicate or usefully deploy. But nonetheless, there's a growing body of evidence since about 2022 on each of these combined elements in use. So in particular, this is just for the sort of sciencey bit, in particular there's a piece of a synthesis of evidence done by Peter Mate, who worked for the IHI, looking at the impact of utilising the 4Ms in healthcare across a range of different settings. And basically they found that in use it has very positive impacts, but essentially the evidence is still quite young. This is again just a similar kind of piece of publication that shows that the actual utilization of the 4Ms in practice has a significant impact on things like transferring older people from residential care to an emergency department. In some of the research, it's reduced by 75%, so very, very significant impacts. So just to give you a sense of where we're at and where the scale of this, there's something like 6,000 healthcare facilities across the world who have participant status, who are participating in an age-friendly health system initiative. And these are spread globally, but primarily in North America. So currently in Mowlam we have 34 facilities that are recognised by the IHI as being age-friendly. And just to give you a sense of scale in relation to that, there's outside of North America, there's very few places that have actually really adopted this, but this is now growing globally. So I think I've covered many of these points really, but basically the 4Ms provide, I think, a common courtesy and a universal language for us to be able to utilize across a health system, irrespective of where the older person seeks help. And to me, that's one of the kind of unique contributory factors of the 4Ms in terms of why this is something that needs to be universally adopted across all elements of healthcare. And if this framework is understood and adopted based on what is now government policy, then it allows all sorts of things to happen that are much more cohesive in terms of the care and integration of that care for the older person. So these are the levels of recognition by the IHI. There's 5,000 plus participants internationally, and there's about 2,700 and growing centres that have got the full recognition from the IHI. And in Ireland, we're particularly fortunate because we already have recognition by the WHO as being an age-friendly country. So the context for age-friendly healthcare is really supported by the idea that at a policy level, we're striving to become a country that's age-friendly. And you'll see that in your daily lives with the age-friendly parking, age-friendly transport. It's becoming much more ubiquitous. And as a system, the Department of Health and the HSE have launched a policy for the healthcare system to become the first age-friendly health system in the world. So that was launched last December, and the intention is to ensure that every element of healthcare in Ireland becomes the first age-friendly health system internationally, which is a very big ambition, but a very welcome one, and gives a kind of policy imprimatur to what we're all working towards. So very briefly, Mowlam, you'll be familiar with it's a provider of long-term care, memory care and post-acute rehabilitation. And we want to work across an integrated system of care, and obviously the 4Ms as a framework provides us with that common currency. So we have 34 care centres with age-friendly participant status, and as of last week we have 13 facilities with full level 2 designation by the IHI. So earlier, as I was listening to some of the kind of principles being talked about, some of the human rights, some of the values being espoused, one of the things that was going through my mind was, well, how do we ground those in things that people do every day? Nobody can disagree with the principles, the values, the need to respect autonomy. But how do we do that in a way that's measurable? How do we do that in a way that we can actually look at with transparency? Well, what happens? How does that look like from the perspective of the resident and their families? And my formative years as a healthcare professional was as a psychiatric nurse. And I worked in those psychiatric facilities where people with dementia were in psychogeriatric wards. And, that for me formed a really powerful sort of impression in terms of values that we've been talking about for decades, about person-centeredness, about how we avoid institutional practice and ritualized care. How do we go beyond compliance with standards? There was a reference to the primetime investigates earlier on, and any amount of regulation, to my mind, isn't going to trump a culture of where what matters to me is really at the root of what it is that people do every day. And how do we make care plans that are meaningful? Because care plans, as anybody here who's a nurse knows, are a very kind of ritualized administrative process by and large. They're not founded on what truly matters to the person. So for Mowlam, when we talked about introducing age-friendly healthcare or an age-friendly health system or becoming an age-friendly health system, we wanted to go beyond HICWA standards. We want to go beyond a mindset whereby the narrative that drives standards isn't just about if HICWA were to walk in the door. It has to be about something more than that. And we want to also measure the things that people do that give them a sense of purpose in their job every day, not the things that go wrong. We want to be part of an international movement because this is the right thing to do. It has an evidence base. It has a very good philosophical base. It's underpinned by values and rights. So we want to be part of that movement. And we also want to be able to participate in a wider system of care, to be able to use the 4Ms as a docking station for what other people are doing that represents what good looks like. So here again is an example of piece of material that emerged out of our action learning sets by one of our homes, which is a leaflet for residents, families to take away and engage people in a conversation when they visit about, well, what is this all about? You purport to be age-friendly. What does it mean? What are you doing differently? And we want to kind of promote that transparency of action and conversation. So in terms of going from the ideal to the practicalities of what this looks like every day, I'll just share a little bit about what that looked like. Once we have an IHI participant status secured, we want to really make that very overt and place sort of prominent information about that in order to engage everybody in a conversation about what that looks like, staff, residents and families. This is an example from Charleville of a poster that we put up in the reception that kind of declares our intent. These are the 4Ms, they're translated into plain English. This is what we're striving to do in this particular facility. And so there's a clear, unambiguous message that's declared by all that this is what we're all about. To get into the nitty-gritty then of how do you translate the philosophy and the framework into practice, we embed it in everything that people do every day. The care plan structures and the content of the care plans have been changed to reflect the 4Ms. Daily safety pauses and daily huddles have been structured around the 4Ms. The staff are encouraged to come back and not talk about deficits or clinical issues solely, but to say, well, what matters to PJ today is that he wants to go for a walk, he wants to participate in the men's shed next week, he wants to do whatever. We have a data dashboard which is framed around the 4Ms. So for every single resident, we can see what does their care plan look like, has the 4Ms been implemented, has what matters to me been assessed and discussed with them. And how are we getting on when that happens vis-a-vis things like mobility and falls? Our dashboard also gives visibility of things like medication. So there was a question earlier on about medication. And one of the things within the IHIs, or the thing within the IHI's 4Ms in relation to medication, is to stop or reduce high-risk medication. So they actually list those medications that need to be stopped or need to be reduced. And we're working with a company called DigiCare in order to, again, give full visibility to everybody's medication, when it was reviewed, and what reductions were being made. And finally, we've got an online academy which has modules that are obligatory for every member of staff to do. So I think out of the 2,000 odd staff, about 75% now have done all of the modules at this point in time. But this is an obligation on everybody to do their modules as part of their training. Our approach to implementation has been very much about building the road as we travel. So we have an action learning set every month, and we want people who are doing the work to build the road as they travel, to tell us what it is that works, what doesn't work, what's working well, and what can we scale up. So, for example, in the initial introduction of Age Friendly, we will meet with all of the staff in that facility, including staff who may not perceive themselves to be clinical. So the housekeeping, the catering staff, the maintenance staff, all have really important contributions to make and often bring the stories that are most critical to the table. So, for example, when we meet all the staff, we'll often have somebody from maintenance sort of sitting there shyly thinking, what am I doing in this meeting? Or somebody from catering saying, well, actually, I'm not sure how this applies to me. All I did was make sure that PJ had his favourite mug available for his breakfast. And that example is precisely what Age Friendly is all about. The act of being mindful of that and personalising care epitomises what it is that we're trying to do. So we ask people, what does a great day at work look like? And we cultivate those stories because people have stories of good work that they've done that's hidden, that isn't captured in a metric, and that isn't asked about by HICWA. And those stories point to the kind of culture that we want to surface, frame using the 4Ms, and legitimise and amplify as much as we can. So one story, again, from a catering member of staff, talked about somebody who was palliative and who went to learn a particular dish that the person wanted, and talked about the look on the person's face when they presented her with, what he perceived to be one of her last meals. So those stories are really important, and the people who carry the culture are supported in that regard. We have internal champions for this, and it doesn't matter whether you're the director of nursing. Well, it does to a degree matter if you're the director of nursing, but what matters is the person is passionate about contributing to this. So we have resident family engagement that's formalised. We've strengthened those kind of structures within the home so that people who are able to contribute to this can do so. And as time has gone on, more and more examples have emerged of things that are being done that can be used or amplified in other places. So this is a small example of the kind of thing that we try and place beside beds if people aren't necessarily even able to articulate what it is that matters to them, but that information is harnessed and made available when people need to understand what's needed. So, what have we seen so far? We've seen a number of things positively impacted on. For example, in memory care, staff tell us that the nature of the conversation between staff and families have changed because the conversation is no longer about something that happened, such as a fall. The conversation is about, PJ, I know what matters to him, and this is what we've been doing. So a number of things have changed. We've been partnering, for example, with Age Friendly Ireland. So if a local community has an age-friendly designation, we want to ensure that the people who are in residential care in that community are part of that, of what that age-friendly community means for them. We've been also working with the ambulance service to, for example, avoid ED transfers where the default was to do that. And that's obviously a work in progress. And we've changed a number of other things, as I mentioned earlier on. So, don't just take our word for this. We've partnered with Rose, who unfortunately couldn't be here today, and her team in the University of Limerick. And we've got 2 studies going on simultaneously. The study in relation to memory care specifically is, we believe, the first of its kind in the world, where an age-friendly health system has been applied in that context, and where we will measure the impact of that in order to provide the evidence for that going forward. And we believe this is, if not the first, then certainly one of the first of its type. And these are the aims of the research, which is to understand the implementation, understand the impact, and understand how we can scale it up. So what next? We want to build on the data and the insights into the data to show that if you address medication, mobility, and mental health simultaneously through the lens of what matters to the person, then that has a real impact on the person and their quality of life. We'll continue to promote training, we'll continue to do the research, we'll continue to partner with Kim and Engaging Dementia in the context of the older person or the memory care facilities, and continue to collaborate with the IHI to develop this across European partners in particular. So here's a picture of Rose with a guy called PJ also. And Rose was one of the first people I met when we were rolling out the age-friendly health system. And she was looking at me kind of quizzically when I was describing the 4 M's and the evidence and so on and so forth. And she said, "Oh, actually, PJ, I think I get it." The other day, somebody asked me to go for a walk, and I said, "Okay." And as we went out, it started to pour rain. And she said, "I don't think it's a wise thing to do. We better not go out. It's raining." And the person said to her, "Rose, I want to go out. This could be the last time I feel rain on my face." So that, I think, epitomizes, behind all of the science and all of the things that we're trying to do, what matters to the resident, and how can we make sure that everything that we do is channeled through that particular lens. Thank you.